Hi, this is Dr. Eric Westman, and welcome back to my podcast. I'm thrilled to have Dr. Jason Fung on the same podcast with me. Jason, how are you doing?
I'm good. Thanks for having me here.
It's been a few years since I think we were at a ski place some years ago at a keto meeting, and that it's been a while. I'm really thrilled to see your work thriving. And tell me what's new, and then we'll go back to what's old.
Yeah. So it has been a few years. I mean, I think it was COVID. I mean, we used to get together all the time, right? We used to see each other, a couple times a year at these meetings at least. And with COVID, of course, everything sort of just stopped. So that was unfortunate, but life moves on. So yeah, in the meantime, I've sort of gone back a little bit more to focus on sort of just my clinical practice and so that sort of thing. So that's where I've been putting a lot of energy in. I've been working with a couple of because I'm a clinician predominantly. I'm not a researcher, right? I deal with people, so that's where my passion sort of really lives. So I went back to sort of doing more clinical stuff. So I was trying to help a company called Level 2 Health, which is its goal is to really help people put their type 2 diabetes into remission, and to do it in a sort of larger scale because they're part of United Health, which can, of course, bring it to a lot of people. So I've been spending a lot of time doing that, trying to put together a program for people to really help. So it's part of United Health, and they're trying to sort of make it more part of their core sort of offerings, which I think is very exciting. I mean,
Yeah.
if you look at type 2 diabetes, which is, of course, where how I sort of got really interested in the entire topic of weight
Well,
loss.
let's start there. Let's go back. Dr. Fong, he was a nephrologist, and like a lot of doctors, he got fed up and wondered why are people needing dialysis? And how did you get started, and how did you kind of, I don't know, it's like a wake up or a transformation for us. It happened to me too.
Yeah, it was sort of a gradual process. So, like you, I train very conventionally. I just, so I deal with kidney disease. And over the years, of course, type 2 diabetes became more and more of a problem. We know that from all our sort of epidemiologic data. There's been more people with type 2 diabetes, which led to more type 2 diabetic kidney disease. And so I was seeing a lot of it, of course. People going on to dialysis. If you look at the dialysis population in pretty well all over North America, it sort of exploded in the last 20 years. So what you see is the sort of obesity epidemic from the late 70s, and then an epidemic of type 2 diabetes happening sort of around the late 80s and 90s. And then sort of 10 years from that, you get all the sort of sequelae or the sort of complications of diabetes, including kidney disease. And you see the dialysis population, which is end stage kidney failure, really start to explode in the 2000s, 2010s, just as I was sort of starting practice. So I started to see more and more of this. And really, it is a very unsatisfying sort of thing to treat type 2 diabetes and type 2 diabetic
But
kidney
you
disease
you
conventionally.
manage it, right? With
Yeah,
drugs. I hate that
yeah,
term, managing. Uh, but
exactly.
I wonder, but before we go further, tell me, so nephrologists can do lots of different things and practice can be done in different ways. What percent of your time was actually at the dialysis centers, I guess they're called? And just to give people an idea,
Yeah, probably
you're
about
managing,
50% of my
so
practice was
half
dialysis. Yeah.
half your daily hours were treating people who had no kidney function anymore. It was
Yeah,
that
that's right. Yeah.
hemodialysis.
So
So
hemodialysis and peritoneal dialysis.
yeah,
And because they're very sick people, they tend to take a lot of time. So
well, it's a
that's
lot of
where,
work. It's hard
yeah,
work.
yeah.
I have to just say, I was in awe of the nephrologist and the kidney. Basically, you're substituting just about every function the kidney does, not all though. but the idea that an organ fails and then a nephrologist basically has a machine that keeps the kidney function going. But what was it like to deal with people who are they're basically tied to this machine, right? Their life.
Yeah.
So some people think, oh, well, I'll just go on dialysis. Well, it's not a great sort of situation to have, is it?
No, it takes up your whole life basically, because it's 3 times a week for hemodialysis, 3 times a week, 4 hours at a time. So by the time you include setup and all that, that's 4 hours on the machine. By the time you include sort of setup and cleanup and getting to the hospital, getting to the clinic, getting going home, and recovering from it, it's sort of 5, 6 hours every 2 days sort of thing. So it's a significant chunk of people's lives. On the other hand, it's, prior to
Like say,
dialysis, you died of kidney failure.
yeah.
So it really is a technological marvel. Actually, if you think about the major organ systems, it's really the only one where it can go to zero and you can still live. Like if your heart function goes to zero, there's no machine that will keep you
Well,
alive, right?
oh, Duke has one of the biggest LVAD programs, the left ventricular assist device.
Yeah.
And like you, I've been using this method with people who are sick. And when the first patient came to me who had no pulse and had a battery pack, I was rapidly brought up to speed that there are a lot of ventricular assist device heart failure
Yeah.
patients at Duke. And I help them lose weight for a heart transplant, which is so actually yeah, there's no liver substitution, right? And then the lung substitution, you can't stay on a respirator. Although COVID, there were lung transplants, and there are lung transplants being done. But yeah, so kidney dialysis is really pretty awesome. It's hard work, and I have to say it's a moneymaker for the system, is it not? Because
Um,
I saw the a community have a choice. They had all this casino money, and they could either do prevention, change the diet, or they could build a dialysis center. And they built a dialysis center.
mhm.
No, you don't want people to have dialysis. Well, but so how did you then figure out you could stop this from happening?
Well, yeah, I mean, dialysis is sort of it's a big imposition on people's lives for sure. And the problem is that it's unsatisfying to take somebody to follow people because, I'm a clinician. And so I follow people and they start with their diabetes, and I see them when they get their kidney disease, and then it gets worse and worse and worse, and then they go on dialysis. So all this time as I treat them, they're getting worse. So that's not very satisfying as a profession, truthfully. So I really
Well,
started to think about it.
kind of like me, it wasn't a good fit for me to see my patients getting worse and worse and worse at a VA hospital. And I have to
Mm.
say, it doesn't seem your personality is so great and bubbly. You want the happiness to have that as a daily drudge. This is a common theme among doctors who went into medicine to actually fix things or make people feel better. Yeah, it's not satisfying for the doctor.
Yeah, and so that's where I started to really think about, you know, why is this happening? What can we do differently? And that's where I started to sort of come to the conclusion that we're sort of looking at the problem all wrong. Like we were treating this disease, type 2 diabetes, as if it was a chronic and progressive disease.
That's what they
And
teach.
that's what they taught it. I actually in 2014 and on one of the early YouTube videos I did, I said it was one of the big lies of type 2 diabetes. Because if you think back then, 2014, you would go to the American Diabetes Association website and they'd state to you plain as day, this is a chronic disease, which means you're going to get worse until you die, right? Not a great feeling for the patient, not a great feeling for the physician. And the thing is that it was obviously and clearly a lie. There was no possible way it was true because you and I knew And everybody else knew, patients knew that, hey, if you lost weight, that type 2 diabetes would either get better or go away. Everybody knew somebody who was like, oh, I got diagnosed with type 2 diabetes. I went on metformin, but I got serious about my diet, exercised, lost, 20 pounds, got off all my medications. Now my blood work is perfect, right? So,
Yeah.
like clearly, like the clinical experience was that this was a reversible disease. We saw it, we heard it, we knew it. Everybody knew it. And yet at the same time, our professional associations, our teachers, our clinicians, our academics were saying it's irreversible. It's like, what the hell are you talking about? I see it on a daily basis, but clearly we are focused on the wrong thing. We're so focused that this was chronic and progressive and that we should, drug the hell out of these people that we forgot to take a look at the people who are actually reversing their disease, because they did, of course, right?
Don't don't you think a big element of this is that there's a medication focus
Oh,
in
for sure.
Western medicine? To me, it's medication care now. It's not
Yeah,
medical.
it's yeah, and I've
Yeah.
it's unfortunate, but it's sort of the way medical education works and
Yeah.
medical research works,
Because
right?
they need to know, the medical students need to know the mechanism that the drug is going to use.
Yeah.
And that's what they put in medical school. This
Yeah.
is backward, right?
It's backwards because if you think about what how doctors get taught, a lot of it is unfortunately driven by pharmaceutical money. Like you look at any association, American Diabetes Association, American Heart Association, Cancer Association, you look at who funds them, right? And you've got this huge list of pharmaceutical companies, right? So if your big meetings, and so as a clinician, so you and I, we go to a big, for me, it's a nephrology association meeting. Well, millions of dollars have been pumped in by drug companies, dialysis company, whatever companies, right? And so therefore, all you're seeing are speakers that are sponsored by the drug company. And there's nothing wrong with drug companies. I'm not anti-pharma, but pharma is focused on selling its drug. So if you have a drug that's made by, a company X, then that company is going to find a speaker to talk about that disease that that drug treats and why that drug is so good. Of course they're going to. What you have
Yeah.
to do as an association is say, we're not going to take any money from anybody. We're just going to hold our meetings for
Well,
scientific integrity, but nobody
well,
does that, right?
as past president of the Obesity Medicine Association, we require people to pay to be in our vendor area. So,
Yeah.
you have to have money to be able to be in these. Anyway, back to how you got into this. So you're dialyzing folks. I mean, what drew you toward nephrology? It's different.
Nephrology, yeah, different specialties have all their own sort of
Yeah.
personalities, which is
I mean,
which is
you're much
interesting.
more colorful and animated than most nephrologists.
Nephrology, I liked it because it's a sort of I like to think about problems and why they occur and stuff. Because in the end, a lot of kidney disease winds up being dialysis. So there's a lot of physiology, there's a lot of thinking about stuff, which is sort of that personality of a nephrologist, right? So we
Can
like
you
to think about
help me understand? In fact, I wondered if one day you would write the kidney code, because the kidney as a self-contained organ actually is one of the few organs like the liver that can make glucose. And
hmm,
it's in the fine print of medical textbooks that the liver and the kidney can do
yeah,
gluconeogenesis.
looking into vessels, yeah.
And I've always kind of anthropomorphized that the kidney was going to take care of itself and not rely on any other glucose input, because there's an area of the kidney that requires glucose.
Yeah.
And that's the renal papilla.
And
There's the
right.
oxygen tension is so low, and this is one of the pimp questions I have for medical students, was what cells really require glucose? And they say brain. Nope, nope. I mean, maybe some glia, but no. So it's the red cells, the white cell respiratory burst, and then this little area of the kidney needs
That's right.
glucose, but the kidney makes its own glucose. Now, I've thought that that glucose the kidney makes could supply it to its own organ. I'm not sure about that. If it gets, and even
I'm
then
not
there
sure
was
that,
a
yeah, I'm not sure how much it makes actually. I
well,
don't know if
and it
it's,
depends on the context, right? Because the
yeah.
brain is going to use glucose if you're a carb eater. The kidney will probably won't make glucose if you're a carb eater. So that if
Hmm.
you're now relying on the gluconeogenesis, what was amazing, there's so much not known still, and the SGLT2 inhibitor drugs that make the kidneys leak glucose, and people are getting infections now there, is stimulating new science. I even had a brush with a fellow who was looking at the kidneys of animals who were dying on these SGLT2 inhibitors, and they were finding that the kidney is doing a lot more than ever was thought in the past. We're learning a lot more about ketosis, keto metabolism, and even then, the kidney is an amazing thing. But then, you weren't just satisfied in dialyzing folks. Tell me more about that.
Yeah, so I mean, as it became more and more of a problem, type 2 diabetic kidney disease, of course, it was sort of the wrong thing to be doing because if it was a reversible disease compared to a progressive disease, then of course we should have been trying to reverse it and prevent people from getting kidney disease as opposed to just sort of managing it or treating it, right? It's a totally different mindset. I mean, it's totally different. And the focus, of course, was weight loss, right? That was the key. When you look at all these people who are doing very well, what were they doing? And a lot of them wind up losing weight. And that was the real key. So if and again, it's one of these things that's sort of so bloody obvious when you think about it. So if you lose weight, your type 2 diabetes often gets better or goes away. So think about this chain of events. Type 2, so diabetic kidney disease is caused by type 2 diabetes. Treatment, got to reverse the type 2 diabetes. How do you do that? Well, you got to lose weight. So the root cause of the whole thing was the weight, and you got to focus on that. But how much of my daily life prior to this was focused on getting people to lose weight? The answer was 0% of my time clinically as a doctor, right? And
Well, you
it's
were
like,
busy.
what the hell?
You were
Right?
busy
But
doing your work.
I know it was, but it was the wrong work. You know what I mean?
Yeah.
Because it's like, think about it. You have this disease that we should have been focused so much, like 50, 60, 70% of the day is focused on type 2 diabetes and their various manifestations and kidney disease. And yet, zero of my time was spent thinking
Yeah.
about the diets that were important because I was thinking about the drugs that I wanted to put them on. Right. And the whole thing was all wrong. And it was because of the way I was taught, the way really everybody was taught. And that's where I started really talking about it, writing about it. And, that's where we sort of, our paths sort of crossed.
Yeah, well, and one of the brilliant, so you have so many brilliant ways of saying things, and as the stuffing passengers in the Tokyo subway,
Yeah.
or the overfilled suitcase, you're trying to get the clothes in there, so that there's another fundamental difference that the cause of insulin resistance, right? The
Yeah.
idea that there's something wrong in this cell, and we just give a medicine, we can fix the insulin resistance without regard to the inputs, without
Mhm.
regard to
Yeah.
the glucose, carbs raising insulin. So what is the cause of insulin resistance?
Yeah, the cause of insulin resistance, and this is so insulin resistance is sort of when people say what causes type 2 diabetes, they say, well, it's insulin resistance, right? And that term itself refers to the fact that one of the functions of insulin is that it opens up these sort of channels in the cell and allows the glucose in the blood to go into the cell. The cell will now burn it for energy. So that's great. That's what's normally supposed to happen. When they look at type 2 diabetes, of course, they see that there's plenty of glucose in the blood. That's how you make the diagnosis. So the question is, well, why is there too much glucose in the blood? In type 1 diabetes, there's no insulin. That's why, right? The insulin can't open up these gates to allow the glucose to go into the cell. Inside the cell is starving because there's no glucose. Outside in the blood, there's like tons, right? So if you think about like a restaurant or something, and you have the doors locked, right? So inside it's empty, outside everybody's waiting around, lined up, right? So the
Type
in type
one.
2
Type,
diabetes, in type
yeah.
1 diabetes, yeah.
Yeah.
In type 2 diabetes, they imagined a similar situation, right? So they said that, hey, there's insulin around, so that's the difference. Type 2, type 1, there's no insulin. In type 2, there is insulin around. So people have the key, they're trying to open the door, but something's blocked, right? So the door is not opening, the glucose now cannot get into the cell, and you're going to get this similar situation where the glucose is piled up outside the cell. And the problem with that is that if you think that that's the problem in type 2 diabetes and insulin resistance, you could sort of follow that logically. If inside the cell there's no glucose, well, people should be extremely thin as they are in type 1 diabetes. They should, basically starve, internal starvation. They shouldn't have a big fatty liver, right? Because fat is a source of energy too, right? So it was all wrong because type 2 diabetes, of course, you have people who are overweight, big fatty livers and so on. So there's a second alternative to thinking about this problem of why there's so much glucose and insulin outside the cell, and that's the possibility that that cell is simply overfilled already. So if you have, say, a restaurant or a train or whatever, and it's already packed to capacity. So say you have a restaurant and there's people, completely full, the restaurant completely full, people have already jammed the inside. You open the doors, people still can't go in because you've already got too many people in there. So you think about a
Yeah, but
cell.
that's just restaurant resistance.
Yeah, that's right. So the same thing in a cell. If the cell has way too much glucose, well, even if you open up the gates with the insulin and say, okay, glucose, you can now go in, it can't because it's full. So then the glucose piles up outside and you say, okay, that's the problem. Now, if you think about this overflow paradigm of type 2 diabetes, it makes perfect sense. If you have way too much glucose in the cell, you're going to have de novo lipogenesis, you're going to have fatty liver. As the liver fills up with fat, it's going to try and get rid of that fat, right? Because it doesn't want fat. Liver is not a place to store fat. Fat cells are a place to store fat. So the liver now tries to shuttle all this extra fat out, right? Because you've turned the glucose into fat. That's what de novo lipogenesis is. You shuttle all this fat out. Well, how do you do that? Well, you do that in VLDL, right? Which are triglyceride-rich particles. So what happens? Well, you have fatty liver, you have type 2, you have high blood sugars, you have high triglycerides, right? Because you've got your VLDL has gone up, which lowers your HDL and low HDL. So now you have one, abdominal obesity because you're shuttling all this fat outside. You've got high blood glucose, you've got high triglycerides, you got low HDL, and you get hypertension because the hyperinsulinemia causes hypertension as well. Well, those five things are actually the five criteria of metabolic syndrome. And it's all caused by the same thing. So that's why those five things all go together of metabolic syndrome, because they're all caused by hyperinsulinemia. You've got too much glucose and too much insulin. You've got overfilled cells. The body, the liver is just trying to get rid of this excess toxic, load and causing the rest of these manifestations, which so all of metabolic syndrome can be explained by too much glucose, too much insulin. It's hyperinsulinemia.
Well, I know we both did our own due diligence and read back into the history, but it's always good to have Gary Taubes put it all together in his new Rethinking Diabetes book. But what that highlighted again for me was that doctors were using insulin to treat type 1 and type 2 diabetes before it was known that the insulin level was high in the blood. So
Yeah,
that and just by the more insulin you use for type 2s, you reach this kind of curve where it just stops working. I've had people, so the U100 insulin, you don't have enough room. You go to U200, meaning double strength, and then I have someone on U500 insulin that is just again stuffing the person in the Tokyo subway. You're
yeah.
going to have some damage if you're not all the way in the
Exactly.
train.
So
You know,
yeah, exactly. It's the same thing because if you give insulin, the insulin doesn't get rid of the glucose. what it does is it takes the glucose and just shoves it back into the cell. So just like if you have a subway train which is too full, you can keep packing more people in, right? You get people, you get, these people on the Tokyo subway where their whole job is to just shove people into the subway car. So that
Well,
only makes the problem worse,
so
right?
if insulin's, I'm just trying to think historically, doctors and pharma, well, if that's not working, well, let's just let the kidney leak glucose. And I
Yeah.
remember going to a GSK GlaxoSmithKline meeting years ago. I had the new, low carb data. I was all excited and naive. And I went in and said, here, you might want to study this, a drug company, but you might find a mechanism, this was, again, it was 15 years ago. They said, oh no, that LDL increase a little bit, FDA won't let us use any drug that raises the LDL, even a little. So I said, well, what are you working on? And they said, well, we have these new drugs that make the kidneys leak glucose. So people can just basically eat whatever they want and they can pee out the sugar. And I'm like, I don't think this is a good idea, as an unpaid advisor. And now we have these SGLT2 inhibitors that leak glucose. What do you think about that pharma approach?
I think the pharma approach, it does work, obviously. People do leak glucose and their blood glucose comes down. It's not a perfect solution, but on the other hand, it's not as bad as, say, insulin because so it's sort of levels of badness, if you will. Insulin, to me, is the worst because you have a situation where your insulin levels are too high and you're treating it with more insulin, which is like, okay, that's insane. Like it's like treating a hyperthyroid patient with thyroid pills, right? You're making it worse.
So
So,
the other pharma approaches, the Ozempic, semaglutide, GIPs, and GLP-1s, they've the diabetologists now actually have medicines that can help you lose weight without, so using insulin basically puts people in this cycle of weight gain. And if weight is the cause of type 2 diabetes, it's never going to fix it. But that leads to the ADA, the Diabetes Association, saying it's a chronic disease because everyone was using insulin. It's like the
yeah,
doctors were, it was a fait accompli. You're basically sentencing people to a lifetime of diabetes if you're using insulin. So,
yeah,
and these non-insulin companies actually are an ally against insulin. I mean, philosophically, because they make money by using their medications. And but let's get back to. If you enjoyed this video, be sure to like, subscribe, and hit the notification bell, and check out adaptyourlifeacademy.com.